Good morning. I guess it's just good afternoon here on the East Coast. For those of you in other time zones, good morning. Thank you for taking the time to join us today in our continuing series on COVID-19. Today, we're going to be shifting the emphasis of discussion a little bit away from what to do in the moment as it relates to the disease itself with respect to testing and identification, quarantine. We've had hosts of experts in the past talking about that. And today we're going to really look at a different issue with respect to this to this pandemic and this epidemic in the US, which is specifically that around the vulnerability of certain populations with respect to their own morbidity and mortality should they in fact encounter COVID-19. Employers feel somewhat on the defense all day, every day about this epidemic. And we think that it's appropriate to keep everybody informed about virtually everything that they can do to protect the health and welfare of their employees and beneficiaries. And I don't think we speak enough about what we could do about vulnerable populations. In that regard, we're going to be looking at the impact on people who, in fact, have lifestyle illnesses. We know that COVID does affect certain people with background comorbidities in much more severe ways than others, and we'll be examining that issue. I'm really pleased to have with us two just phenomenal panelists who are going to make an enormous contribution, incredible, interesting discussion today about this whole topic. The first is Craig Kurtzweil, who is a VP at UnitedHealth Care, and he leads their Center for Advanced Analytics. He's been at UnitedHealth Care since 2005, where he helped form a team of strategic customer analytics specialists. And really now he runs what's called the Center for Advanced Analytics, and he focuses on analytic innovations that change the way UHC evaluates its own healthcare value that it delivers to its clients. They really look closely at highly complex issues, and what he's going to discuss with us today is what they have been seeing since the onset of the epidemic in America on the utilization of the beneficiaries on all sorts of health services. And I will tell you, it's not often that I see jaw-dropping presentations, but when Craig and I had the first discussion and he sent out the slides, some of the slides and some of the data, I think you'll agree that there's really some really stunning observations that he's going to share with us today. The second guest is somebody who I've known now for 2 years, Dr. Tonya Walker, MD, MPH, and she is the Chief Medical Officer for Unilever North America. Not only is she a fervent patient advocate for better health, she's charged for all of the medical and occupational health function across America for Unilever. She's also their pandemic lead for COVID-19, and she manages all the COVID-19 case management and contact tracing programs. She works very closely with the supply chain and informs the company for all in America for all protocols and safety protocols across the entire enterprise. So first, I really want to thank you both, and I think that we're going to have a very interesting time today. I'll go over a few slides just to show folks what we think about and the impact of lifestyle and comorbidities and what we think preventive health can do to help those people. Then we'll have Craig talk about some of the data on what people have been doing much less of in America since this epidemic started. And then we'll have Dr. Walker talk about what she has been seeing as it relates to her employees and beneficiary populations for Unilever. As usual, we tend to keep this fairly short, 20 minutes, half an hour, 40 minutes maximum for my presentation of the panelists, and we leave lots of time open for questions and answers. For all of you on the webcast now, feel free to just go into at any time into the Q&A and type in a question, and we'll direct it to either Dr. Walker or to Craig or to both of them. So with that, I'm going to begin, and this is the most difficult part for me, is to get the technology right. So I'm going to hit the share screen and pull up our first piece of the overview here. And really what we're going to be talking about is what we at EHE Health have begun to look at very closely. As you know, we're all in the preventive health and primary care business. And when this epidemic exploded and we started to see some of the mortality data and morbidity data, we really took it upon ourselves to say, hey, is there something more that we can be doing for those populations? To refresh, and for those people who haven't specifically haven't been focused really on this issue, there are some underlying lifestyle illnesses like cardiovascular disease, diabetes, chronic lung disease, and chronic kidney disease that truly do affect your outcome if in fact you should encounter COVID-19. And as we know, this is raging across now much of the south and southwest of the country. We really had a terrible time of it here in the Northeast in March, April, and May. And the data has subsequently emerged about what the impact is of having encountered COVID with some of these conditions. Sometime in early June, the CDC published these data. And I tell you, my heart breaks. I look at this. We had, then I thought, oh my gosh, we have 1.3 million cases, and now we're well over 5 million cases. And you can see, that this thing really hasn't obviously abated, but they were starting to accumulate really interesting data. And I think when you look at this slide and you really focus on what's going on here, that where you see the bold 6 times and 12 times, people with underlying medical conditions, the conditions that I highlighted on the previous slide, have a 6-time hospitalization rate when testing positive for the novel coronavirus, 45% versus 7%, and a 12 times mortality, almost 20% mortality versus 1.5% mortality. And when researchers looked at exactly what those conditions were, it was basically cardiovascular illness, blood pressure, heart disease, diabetes, mostly type 2 diabetes, lung disease, chronic lung disease, and then kidney disease. And what should be intuitively obvious to everybody is that these are the major conditions that have a huge lifestyle impact, and if not just lifestyle alone, are frankly quite easily treated with good preventive health care. New York City published some data about 5,700 COVID-19 patients admitted to New York City hospitals during the worst time of this epidemic. And again, the figures here are just stunning when you look at who really were at high risk. And this is, by the way, notwithstanding age. Obviously, we know that as you get older, you're more at risk. But even people who were younger with these risk factors, those are the ones who tended to have a real bad time of it. And you can see obesity, 60%, hypertension, 56%, type 2 diabetes, and the list just goes right down. And so the big message here is, okay, although we don't have evidence that we, in fact, prospectively modify these risk factors because the studies obviously haven't been done, but you know what they say, if it walks like a duck and it quacks like a duck and looks like a duck, you don't really have to do a genetic sequence. It's probably going to be a duck. And when we look at these data, you say, my gosh, when you look at these easily modifiable conditions, I think that you could have a good intuition that if we all took care of these conditions more optimally, likely we would have better outcomes if in fact people did encounter COVID. So this really interested us as a company, and we looked at what would happen, what was the impact of prevention, and we have several 100,000 patient years of data, but we looked at about 37,000 cases for all of our clients across all geographies in the US, and we looked at who in fact had any one of those risk factors, and about 40% of people have at least one risk factor in our total population, and 12% had 2 or more risk factors. And by the way, 2 or more risk factors is a much more dangerous situation if you would encounter COVID. And what's interesting here is on the left-hand side for on these left-hand graph for people who have had 1 risk factor, and then you look on people who've had 2 risk factors and it's divided by age, you can see in the light blue graph, those are people who are serial patients, they're returning patients for routine preventive care. they have a very highly statistically significant reduction in comorbidities versus our first-time patients. And I'm not putting this up because I want to advertise the HC in particular, although obviously, I have an abiding interest in that. But the fact of the matter is no matter where you get preventive health, and if you get good preventive health, that you can in fact reduce your comorbidities. And we think that this was really a stunning observation. And this caused us to go back to all of our clients and say, look, here's the folks who haven't been able to get in. And many of our clients really came to a call to action and identified those patients, said, look, we can do, there's no treatment, we have no antivirals, we have no vaccine, but the very least you can do is try and optimize your current health condition. And the purpose for this webcast, and I think the purpose for people who are in the arena of preventive health, is to say, look, at times we all feel depressed and anxious about what's going on in our country as it relates to this pandemic. We're healthcare providers, and we take care of very large populations. But there are things that we can do, and this really was a call to action, and we really aren't powerless. And right now, in the midst of this epidemic, it really is possible to do something, and everything that you can do. And let's not forget those lifestyle factors that increase people's vulnerability to this particular condition. And doing as much as we can in the moment is going to be, frankly, the very best that we can do. So I'm going to stop there. People can have questions for me on this data. Feel free to go ahead. I'm going to stop sharing the screen and allow Craig to do a few introductory statements, and then I'm going to put up the slide that he will be sharing with you. Craig?
I'll take the baton, David. Thank you. So in that same vein of some of the issues and comorbidities that come along with COVID and the exposure to high risk and mortality, we've been studying a lot of that and agree completely with what David just kind of walked through. What we were also starting to see, especially as we're talking with employer clients that are struggling with, what do you do about this? There's not so much you can do around COVID, but what can I do as an employer to really help during these times of need? And one of the issues that we find people aren't talking enough about is the ripple effect, the impact that COVID has had on population health beyond just people that are contracting the disease. As hospitals shut down, as outpatient surgeries and those types of visits became very, very limited, if non-existent, we started to see some really remarkable data that show there is an opportunity for employers to really make a difference. And if the slide I show you doesn't impact you, I hope it does, because I think there's a real call to action that there is something that we can do. And there is a big gap that's out there in the US healthcare system that isn't in the headlines, but is truly a huge impact that COVID is having. So David, if you wouldn't mind throwing up the slide, I can talk through that a little bit. So what we've been doing is looking at across a good chunk of our book of business across UnitedHealth Care to look to see what happened during what I'll call the COVID season. So this is from the middle of March through the end of July to start to see what kind of choices were folks making when it came to preventive care. There's a lot of things on here. I'll pick off a couple just to kind of talk about, but say on the far left, when you look at just kind of general wellness visits, during this 5-month period, wellness utilization, just general wellness visits, down 30% compared to 2019 during the same 5-month period, which you would expect with some of the provider offices being shut down or very, very limited. But what you see on here that, again, doesn't get as much conversation, there's some big numbers on here: mammography screening, colonoscopy screening, far right, looking at vaccinations, chickenpox, measles, mumps, those kinds of things that we used to, as a healthcare system, take for granted, that all of our employees, that the population generally understood, at least 99% of the population understood, and we didn't communicate, incent, engage, and nudge people to have these things done. Now, those core blocking and tackling pieces of healthcare are becoming a challenge. We have a huge portion of the population that hasn't been vaccinated in the last 6 months. We have a huge portion of the population that should have had a cancer screening and did not. In the depths of COVID, during the worst of it, in the April, May time periods, we saw these numbers down 90%, 80%. So we are starting to see it come back a bit, but we aren't seeing it come back enough to catch up to the big gap that we saw back during those time periods. So We will be talking about this in more detail. There are high geographic differences around the impact that this has had in the North, in the South, in the West, in the East that I'll be showcasing for you on an upcoming discussion, as well as looking at what we think the ripple effect, the impact of this is going to be long-term on population health, on population cost into the future. If this is just a blip on the screen, that's one thing. If this is a long-term trend over, say, a year, even 18 months until COVID is hopefully handled, we are going to face some significant issues as a U.S. health system. So wanted to just tee that conversation up with you today, but no, we are going to be going into greater detail at an upcoming session. With that
is an amazing slide, Craig. I just have to tell you, for those of us who have dedicated our lives to treating patients and public health, I mean, in this country, at this level of affluence, I think, and the cost that we put into the healthcare system, to see that really is just mind-blowing. I have to tell you.
Just one other comment there. I think that we all kind of take for granted that everything's going to go back to normal. Everyone's going to go back and get the treatments done that they need and get the care that they need. I think with those big numbers and the psychology of what everyone's gone through over the past 6 months, I think we all need to think about we're going to have to go above and beyond to get to even back to where we were before, which wasn't great, but just to get back to where we were before is going to take a remarkable effort by everyone in the healthcare system, or we're going to face a whole different sort of challenges beyond COVID itself.
Well, that's a great insight. Just before we pass to Dr. Walker, could you just remind us the size of that database? How many millions of people are in that database?
Yeah, that cut is about 10 million people.
And you think it's representative of basically the UnitedHealth groups?
Yeah, pretty comprehensive. And but like I said, there are when we spread that across the geographies, like with COVID, it's very local, the hotspots and issues. So once we break that apart, you'll see there's some interesting data in that as well that I think will be an aha moment for you guys. Yeah, very representative of what we're seeing nationally and very consistent. We haven't seen big peaks and valleys in that. It's been a very consistent story. And even if you look at it for specific employers, they basically match what we show within the chart. The only variable is where they live, where their members are. Because if you were obviously in the Northeast early on, you were dramatically impacted by this. But now other parts of the country obviously are falling close behind.
Super. Dr. Walker, thank you for joining us. And we're eager to hear Unilever's North America's perspective on all this.
Great. Thanks for having me, Dr. Levy. And Craig, I mean, that data it's quite telling. I mean, here, Unilever's headquarters in the United States is based in northern New Jersey, right? So right outside of New York City, right outside of the mecca of COVID back in late March, early April. And most certainly I can say anecdotally, we've lived through what your data showed, right? So we've lived through, the ERs being completely packed, mostly with COVID-19 patients. And then as the numbers started to go down, ER was almost like a ghost town in a way that we've never seen it before. And we always wondered, where are all of the chest pain patients? Where are the strokes? Where are the GI bleeders? Where are all of the patients who we are here in the community to serve? And they were all at home still having MIs and still having strokes because they were very concerned about presenting to have health care because of COVID. Or afraid of being exposed and possibly contracting the illness. And so that data is quite telling, and I look forward to taking the deeper dive with you in a few weeks. So I want to just take a step back, if it's okay, just to describe kind of our organization to everyone so that you can understand some of the issues that we face and just kind of create the setting. So we are a fast-moving consumer good company, a global company with 150,000 employees plus across the globe. But here in North America, employees full-time about 8,500, and from any time can have 1,000 to 2,000 contractors depending on the day. And we make brands that people are familiar with, like Dove, Ben & Jerry's, Lipton Tea, Hellmann's, Ben & Jerry's ice cream, for example. And so the types of employees that we have is quite varied. We have your office-based workers, we have scientists who are in our research and development laboratories, and we have our manufacturing or our factory blue-collar workers. And we're also spread throughout the country, so Northeast, Midwest, South, where our healthcare profile of those employees really do vary. And so when we talk about the vulnerable populations in the setting of COVID-19, we're talking about those people who maybe live in places or have cultural lifestyles that don't necessarily match well with preventive types of activities. So for example, we have a site down in the South where, they actually have 95% of the employees meet the criteria of being overweight or obese. And again, it's not because of anything, wrong with those people. It's just that culturally, the types of food that they eat, the smoking, the different lifestyle factors that they engage with are not on the side of health, for example. And as we know, the CDC has very much said that obesity in and of itself, a BMI of 30, is a risk factor for outcomes for COVID-19. And so, our culture prior to COVID was very much about well-being. We focused a lot on making sure that people's mental, emotional, physical, and kind of purposeful well-being was invested in and developed. And we're so grateful that we took that strategy before COVID, because that is already a part of our culture. And now with COVID, we've been able to kind of put the ante on some of our programming, right? So our Thrive program that focuses on those four pillars of well-being. We have a mental health first aid program that now more than ever really we need, and we can talk more about that a bit later. And our preventive health programs, right? So making sure that our employees are accessing healthcare, whether it's through an annual touch base with having a biometric screening, pushing flu vaccines during the season, and then having preventive exams where we work with PHE to bring preventive health exams to our employees. And the way that it works is that, PHE has a set of doctors that we would ask our employees to see, and depending on preventive health guidelines federally, employees will get the preventive screens, whether it's blood tests, mammography, EKG, a stress test, for example. There are parts of this country where just basic access to healthcare is it's challenging, right? So oftentimes you'll hear healthcare access issues in more urban communities, but where our manufacturing sites are really in more rural areas where there are challenges with accessing healthcare, and not just healthcare when you're ill, but healthcare in terms of preventive strategies. And so what we've done is we've partnered with the HE in a very innovative way, in my opinion, where OEHE has local providers. We still weren't seeing the uptake that we would have liked to see to get our employees the preventive health care that they needed. So what we've done is actually brought the preventive care to them, and did what we call a pop-up clinic, a pop-up preventive health clinic at one of our manufacturing sites, where EHE doctors and staff came to the site and kind of literally revamped a part of the factory and made it into a clinical setting where employees very easily can go and get their preventive health exams. And we found that for the most part, it's the first time majority of the employees had ever had an exam like that, a very comprehensive preventive health exam. And secondly, more importantly, really, is we were able to detect early onset of certain diseases. So pre-diabetics, for example, those who may have had some sort of renal insufficiency and were unaware, those who had, possibly been hypertensives, and again, didn't feel it, they were unaware. And so picking up on those people early, and then working with the local health system to get them plugged in, start to be followed, and also linking them with the health mentoring program, so that over the course of a year, they have one person who follows them to help them with these modifiable lifestyle factors, so that can improve their overall health. And that was just last year. That was prior to COVID. So now certainly in the setting of COVID, we want to amplify that, right? And bring it to other sites, because it was a huge success. 90% of the employees who participated in that program said that would change nothing. that it was phenomenal, and they were so grateful that they participated. And frankly, while we're looking at the data in COVID times at that particular site, comparing it to some of our other sites, numbers of employees who are, being hospitalized or who are becoming severely ill from COVID, or even, some of the sites that would be considered, outbreaks, maybe 1 or 2 cases, that particular site has not been impacted compared to some others. And in a very significant way. And I'd like to say that a part of that, in addition to all of our safety protocols and our testing mechanisms, is working very closely with local teams. That part of that is this idea that had been implanted in the population there about looking after your health. I think the move that we made there last year was quite telling, and it's proving itself now in COVID. So, our intention is to continue with bringing preventive health to our sites where we can, and really making sure that we emphasize the importance of just overall health as a mechanism to protect people from COVID-19's poor outcomes, right? Whether it's severe morbidity or mortality, So. That would be my contribution to this. It really is quite telling the importance of preventive health care in this pandemic. It's really important.
Dr. Walker, thank you. I actually did not know of your early data as it relates to the plant that we had gone down to in Arkansas versus some of the other sites. I'm eager to learn more about that.
Yeah, of course.
But I'd like to ask both of you, I think of, we have this expression here, we say COVID compresses time, in the sense that, we didn't know when we started to do those clinics, pop-up clinics, as it were, that we were going to have a pandemic. We were doing it because we thought we were going to prevent morbidity and mortality 20 years in the future. But
Correct.
and then this virus rolls in and basically says, well, we're not giving you 20 years now. If you happen to encounter me, you could have a really bad impact right away. And I think that the way I look at it is, from an employer point of view, what did you think about prevention before the advent of this and the impact of lifestyle, and how long term your horizon was? And then we get into the epidemic itself. How are employers thinking about who to bring back sooner versus later, i.e. more vulnerable versus less vulnerable populations, and how does that factor into the discussion? And then the discussion we just had today, which really is, okay, now that we know more about it, is there something we can do now to reduce vulnerabilities even more? And then ultimately, as it relates to what Craig and United does for a living, is really help people get appropriate utilization and manage the cost and quality of these things. What really is the call to action there? I know it's a long question, but I'd really love both of you to take a crack at it, because we were talking just before we started the webcast, this issue is going to ripple for years as it relates to comorbidities and lifestyle, and the fact that we're not doing prevention because of this. And I think maybe this is the beginning of a much longer problem once we have hopefully a vaccine in the next few months. Maybe there's going to be a bunch of other calls to action here, which I think that it might be best to even start talking about. So maybe Dr. Walker, you could start to think about, you talked a little bit about the pre-awareness of prevention. How does that factor into who's vulnerable and coming back to work? How about, are there any enhanced activities for reduction of comorbidities? And then what happens in the future? And Craig, what are the claims that support all of this, the economics, and what are you seeing in that regard? So Dr. Walker?
Sure. I mean, that is a big question. In terms of vulnerable employees, we had a global strategy developed. And what it said was that there was a list of health conditions and an age, right, that would put you at a higher risk for developing COVID and having a poor outcome. And globally, what they've said is, these people should be removed from the workplace. So our essential workers essentially are the manufacturing workers. They're the ones who are still reporting to the workplace on a daily basis. And also some of our research and development scientists are reporting to the laboratories. They said out of those who are still going into the workplace, remove, those who are 50 years old and older, and those with, hypertension, diabetes, obesity, with a BMI greater than 30 or greater, who are immunocompromised for whatever reason. And scientifically, that all makes sense. All the data that we've discussed already during the course of this webinar supports that. The issue is legally, in this country, in the United States anyway, we cannot do that because of ADA and EEOC regulations, that it can be considered discriminatory, even in the setting of a pandemic that shows that this risk profile puts you at a greater risk of poor outcome. And so what we've decided to do is, since we couldn't remove people, Unilever as the employer remove people from the work site, we have done a very, very heavy education campaign to our essential workers to have them kind of self-assess and self-declare whether or not they should be at the workplace, and have made sure that our HR policies follow suit to support making the right decisions, and so that they are not penalized for being outside of the workplace during this time. And so we're asking that people follow up with their doctors if they're concerned about possibly being considered vulnerable, that all we need, you make it easy for them. We just need the documentation to support that, and then you're out, for example. We also have now developed a kind of a COVID response team of physician assistants and nurses who are available to employees who have questions about any sort of health conditions, whether it be new or chronic, and what that would mean for their risk profile for developing COVID or having the poor outcome if they've already been diagnosed with COVID, and helping to guide them remotely through local healthcare systems so that we can get them the care that they need to help manage that. And so, and also a testing strategy, right? So now we're considering bringing antigen tests on site to help kind of with surveillance, since we know that we still have vulnerable employees in the population who self-decided that, they want to be there, and that's okay, but trying to just kind of maximize the tools that we have available to us to try and protect them the best that we can. So if we're able to pick up any asymptomatics, for example, in the workplace and get them out immediately, the appropriate contact tracing to help to protect anyone who's vulnerable, or even if the vulnerable employee, were to be asymptomatic and test positive, get them out as soon as possible and get them treated. Or, 2 days later, if they were going to become, develop severe respiratory distress, for example, we can somehow get ahead of that. And so those conversations are currently happening. And so those are the ways that we've tried to approach in a very aggressive way our vulnerable employees without being able to take them out of work, which is what we essentially would kind of prefer to do, is to kind of keep them home and isolated to the best of our ability. We also have safe protocols in place to make sure that our sites are safe and try and keep COVID out of the workplace. I think a lot of what you've already talked about in terms of temperature screens, questionnaires, the appropriate PPE, maintaining social distancing, even having auditors located at each site to make sure that all of those protocols are being adhered to, in addition to this new medical team that's being developed and built regularly to help to manage all of these cases.
So just to be clear, if outside of the US, for example, in Europe or elsewhere, you would actively try and restrict who you would perceive to be vulnerable populations from the worksite until you, in a preferential way, to keep them. And here in America, what you're doing is you're encouraging them all to surface and manage the vulnerabilities and to do everything you can to optimize them, considering that you because of the regulatory environment, you can't do that. That's really interesting.
Yeah.
That's really interesting.
It is. A lot of my colleagues, across Latin America, the physicians in the organization, in India, for example, as well, they've been able to remove all of their vulnerable employees from the work site, and they've had to backfill spots with new workers to cover, if that's what it takes to continue the production. But and their employees really appreciate that. But again, the regulational milieu allows for that, whereas here it does not. And so we're doing the best we can to kind of manage the risk associated with them being on site.
Okay, and Craig, I know we lost the beginning of the question, but what's your point of view on thinking about this from different timelines, pre, during, post, and what the future holds? And by the way, I know you may not have the exact data now. Are you seeing from a claims point of view the validation that those people who are getting into trouble in the hospitals, in fact, are laced with all sorts of comorbidities? Are they certain? Is that being backed up in what you're seeing too?
Yeah, I like that. First, so yeah, our data mimics the studies that you're seeing nationally. So the same slides that you showed up, David, we would mimic that. Those we focus on inpatient. So those COVID cases that require inpatient activity, ICU, ventilator, more early on. But a great majority of those cases had known chronic conditions prior to those events. So definitely a key indicator of not the ability to get COVID, but the severeness of the condition, definitely to those comorbid conditions, as well as obviously age being a key condition as part of that as well. And to Dr. Walker's point, we play a unique role in some of those discussions. So we're not, obviously telling who should work, who shouldn't work, that kind of thing. But we get to, we have some of those sensitive discussions with employees about, historically managing their diabetes and asthma and heart disease and things like that. And now it's, how do you manage that? And, are you aware that, these conditions not only have long-term health impacts, but have a short-term impact with COVID being out there. So we've changed how we're having those disease management discussions to bring the COVID risk factor into some of those sensitive discussions as well. Just hit on a couple of points you mentioned earlier, David. So the timing of, by the way, before I hit that, the high risk population, just for, I'm a data guy, so just some numbers around that. Typically it depends. There's lots of different studies that are out there on how you define high risk for COVID. It's ever changing. The science is still not completely locked down. Depends on what factors you consider. But roughly 15 to 25% of a population would meet CDC requirements for a high risk threshold. Just for the folks that are out there, that's the threshold we're kind of looking at broadly. David, to some of your points around preventive care, I think this has changed the timeline discussion dramatically. It's historically been invest now for 5 years from now, or invest now for 10 years from now. And now it's more, as you saw on that slide, it's an action item as far as like, we need to do things now. And the return on investment on that, not only from a monetary perspective, but from a life-saving perspective, we're talking months and not years or decades. So it's changed that completely. The other piece that I think it's changed is, historically, I spend a lot of time thinking about what's the ripple effect of health that it has on an enterprise, not just to reduce healthcare costs, but to improve actual health and to improve productivity and disability and those kinds of things. If we're all doing what we say we do well, we should have a broad sort of impact on an enterprise if we can improve health. And in the past, that would require convincing and some studies and some analytic hoops to jump through to show that there's the linkage between health and productivity, and we've done some of that, but it required some convincing, honestly. But now with COVID, the evidence is there, right? If we can drive your population to better health, not only does it lower your healthcare cost, not only does it make your workforce more productive and more present, but when these kinds of things happen, you're better prepared to handle them. So I think it's brought preventive care wellness to the forefront. Hopefully, again, it's not a blip on the screen. Hopefully this is a long-term transition that now preventive care is to the forefront and is truly seen as an investment in the enterprise, in the employee, in the productivity, versus just, does it drive a medical ROI discussion?
So go ahead, Dr. Walker. Go ahead.
Yeah, no, I really appreciate those comments, Craig, because I could tell you in this organization, we certainly are living through that. We've been large proponents of well-being, wellness, and preventive health. This has only reinforced that, right? Kind of living through the pandemic and the degree of investment that's been required to keep our employees as safe as possible. This has only highlighted that. Right. And so any argument that you have is kind of outside of Unilever between the link between health and economics. If a global pandemic hasn't shown you that, I'm not sure what will, frankly. Right. And so I do appreciate those comments because I use them oftentimes when addressing leadership in the organization. So thank you.
Those are great. You know, we published a paper just right the week before the pandemic at the American Journal of Public Health. We did it with our research partners at the Mailman School of Public Health, and they co-authored with IBM, which was the Truven Group, Truven Analytics. And we basically showed that only about a third of people, despite full coverage from the ACA, actually ever go to their preventive health visit. And frankly, when they go, they don't even get the right thing. Doctors don't know what to do in a comprehensive way, in age and gender stratified, and frankly, patients don't even know what to ask for. And so hopefully that this will bring a new focus on that. But listen, I have a bunch of questions here from people that are really interesting questions, so I'll just direct them to who I think could best answer. The first one was, during the time of social distancing and working from home, how can we encourage employees to engage in the healthcare system and all the programs that their employers offer to prevent the issues that Craig described? So that would be for Dr. Walker.
That's a really great question, because we focus, I think, most of the discussion so far on those who are still reporting to the workplace. And so this question kind of is highlighting those who are now working remotely, but the issues remain the same, right? That still need to be, make sure that they're looking and getting their preventive health care. And so again, what we're doing is very significant campaigns, and we're being creative about it now that we're not all reporting to the office with the big television screens or going to town halls together and sitting in the same room and making these announcements. Now it's being done in virtual town halls and making announcements and using different threads to remind people of the benefits that they have available to them, and maybe even changing our incentive program, so making some adjustments to the incentives to get people to go and have their exams and all of the different preventive screening and vaccinations also, to just highlight that for them, so it doesn't come in the back of their mind, especially in parts of the country where the COVID numbers have improved. We're starting to see an increase of people feeling more comfortable going back to their doctor, feeling more comfortable about getting that mammogram, going and having the colonoscopy, and making sure that we're just highlighting that for them and saying, yes, the benefit still exists, and yes, it's considered safe. You know, whenever the medical team gets any questions, we certainly encourage people to do that.
So that's great. So the next question here is, again, for you, Dr. Walker, and it goes like this. The data that Craig shared is staggering. What recommendation would you have for us to leverage that internal dialogue, so not externally, now internal dialogue, so that employers can make better decisions for our employees?
That's a very good question. I think that showing data like what Craig presented to the leadership to help them understand the importance of investing in the vaccines and the preventive health strategies is going to really be key. Again, that's what really helped me throughout all of pre-COVID, and certainly now as we are in the midst of it, is presenting staggering data like that. Those who kind of hold the keys to the pocketbook, working very closely with our benefits team and looking at what our vendors have to offer, who's being innovative, helping to encourage them to push the needle a little bit and differently, since now we're kind of functioning in a very different type of world. I think those would be the best ways to kind of leverage that data, is really make sure more people are aware of it, because you know we're all on this call, I would think, because of our interest in health and some relationship to it. But a lot of times we're in organizations internally that are not based in healthcare, for example, my organization. And so I'm charged with bringing this type of data to those who make the decisions to make sure that our employees can stay as healthy as they can as we kind of navigate this pandemic.
I would imagine that the internal discussion now has become less, what's the ROI in a month versus isn't this really obvious and people are kind of really suffering? And I mean, this has really changed the dialogue, I think, and the urgency of the dialogue in a little bit of a different way, I would say.
It has. I can tell you prior to COVID, I was having a lot more conversations about ROI. And now, since this has happened, again, this medical team that was built literally blossomed over, 1 to 2 month period. And I would go and say, okay, I need this. And before I could even say another word, they're like, whatever you need to do, right? Get whatever you need to get. Here's the funding for it, because they understand the importance of keeping people healthy in this COVID world, right? Because it ultimately impacts our workforce, our well-being culture, and our ability to make revenue and to business functioning and to keep people employed. Right, and so it's all intertwined and linked. So not much about, I don't think I've used the term ROI since this all started.
Okay. It's really interesting, Dr. Walker. Okay, the next question is for Craig. With many schools likely reopening, does the lack of prevention and vaccines create increased risk for school children beyond COVID? And should that be a reason to keep learning virtual?
That's a weighted question. As I always like to say, I'm just the data guy, so I have no horse in the games. So what I see in the data, so we are starting to study schools reopening to see what impact that has on spread of the disease. The results are early. We're all watching what's happening in Georgia and so on to see if what sort of impact that makes. I would say, as a father myself and making those kinds of choices for my kids, what we do see in the data is that from not the spread of the disease, but to the point of the actual incidence of severe issues and mortality, it's a very different story for children than it is adults with those types of conditions. And I know it's a very, very challenging decision to make, but mathematically, that's what we see in the data. So I do think that it's going to be something that we'll need to study, and we'll need to see. It's not really about do we put kids back in school or not. To me, it's more about what sort of measures are put in place, what protections are put in place, and most importantly, what do you do when it doesn't work? And there's a hotspot that pops up. How quickly do you shut it down? How quickly do you make sure that you take that high risk or exposed population and make sure that they're safe and refrain and hopefully prevent it from being a widespread community outbreak? I don't know. I'm cautiously watching, again, as a parent myself, cautiously watching. I'm not sure we have a direct answer, but those variables matter a lot, and that's what I'm focused on.
Dr. Walker, why don't you take a crack at the same question? I know it's not directly related to as an employer, but you are a primary care physician and you are a public health specialist, and obviously an abiding interest in these things.
Yeah, I mean, it's a challenge. This is, I think, an experiment of a lifetime, is what I would say, right? Because we recently, the science has shown that children from 10 years old to above transmit this virus in a very similar way to adults, right? And even the younger children, they have higher viral loads in their anterior nasal passages, even though they'll be completely asymptomatic. But the fact that they have a higher viral load means that they can transmit this disease quite easily to others. And they're still running around and quite playful, and you would never know. And those others would be possibly those vulnerable teachers in the schools, those vulnerable cafeteria men and women, the teachers' aides, for example, the maintenance staff. And so, or the bus driver, for example, right? And so I really do think that until we get the virus, quote unquote, under control, that school reopening really should be tabled, frankly. And parts of the country where positivity rate is, between 1% and 2%, notably in the Northeast, kind of New York, New Jersey, Connecticut, Maine, those parts of the country reasonably are having discussions about bringing children back into the school, right? And having teachers kind of self-proclaim, again, because we're still in the United States, self-proclaim whether or not they are vulnerable and whether or not they would go back into the workplace. But in other parts of this country that are currently being essentially ravaged by this virus, I'm actually shocked that we really are having conversations, or schools have really reopened, right? We've already seen several schools, especially in some of the southern states, reopen and shut down within a week of reopening because of outbreaks. And so know, I would agree with Craig that yes, you want to make sure that you have all of the safety measures in place, but then what do you do if and when those measures fall apart, right? And what constitutes an outbreak in a school? Is it one case? Is it two? You know, there's so many questions, and you test, right? So in the university setting, they are talking about testing. We know that ideally, if you're going to test for antigen, that you should test every day, but logistically, that's not necessarily feasible. So testing every 1 to 3 days, you know, there's so many different variables to consider and so many variations, but I think at the core of it, we shouldn't even have those discussions in a meaningful way until the community level of disease has been suppressed to the point where it's safe to bring children and adults back together again that are not all in one household.
We really agree with you.
Just
I'm
to
sorry, go ahead.
add on, Dr. Walker, I agree completely. And it's the same conversation that we have with our employees. It's not about necessarily if we're truly trying to mitigate the risk of mortality and severe conditions. It's recognizing the signs that there are high risk populations. The goal of all of this should be how do we make sure that we keep safe those high risk populations. So it's not about the kids and the spread, and it's the real is how do we make sure that that doesn't lead to a high risk individual being exposed, whether that's our employees or our kids in school. If you really get to the math, that's where I focus is that's the key piece is it's not about the exposure, it's about the exposure to high risk. And how does a community, how does a school, how does an employer make sure that that doesn't happen? Because that's the biggest risk that we face.
Correct.
Great. Okay, so I have another question here. I think we can I'll take, I think we should all take a crack at answering it because it's a fairly generic question. It goes, what would you recommend in terms of encouraging clinical visits and balancing messaging about being cautious and staying safe? So, you know, from our point of view at EHE, you know, we've not only taken extraordinary care, you know, at our own facilities, you know, in a wide variety of ways. We've actually tried to promulgate those standards across our network of physicians. We have over 300 participating physicians. I will tell people on the phone, you know, we don't have a national strategy in that regard. And so many of these physicians are kind of leaderless with respect to how they keep their practices safe and the like. And so we've really felt that we've had to, and we're proud of it. We stepped in to help them put together some, just like pre-pandemic and during the pandemic itself and post-reopening, we've stepped in and really tried to help give them some good guidance. You know, I think that, you know, back to what Dr. Walker said, I think that if you're living in a community where what we would call the R0 or the transmissibility factor is less than 1, that's a completely different conversation than when you're sitting in a community where the transmissibility factor is 3 or 4 or 5 or even higher. And, you know, we follow in all of our communities every single week, every Monday morning, we review where exactly the transmissibility factors are greater than 1 and which communities inherently are at more risk. You know, I like to say a lot, you know, managing this has kind of 2 pillars. One is I call it Public Health 101. We know how to manage this. Public health knows how to do this, you know, detect, isolate, you know, quarantine, contact trace, repeat. And that's pretty much basic. But in a situation, the second pillar in a situation like we have is you definitely have to customize your approach depending on what's going on in the region in question. So it's a combination of really strict Public Health 101, where I think it's perfectly safe. And then the more you get into a situation where the transmissibility factor is going up, it does change. I will say though, you know, I've personally visited all of our facilities around the country. I know it's crazy. I'm 65, but I still, you know, I went out and did that. And it was important to us to see how people felt. And for the most part, healthcare providers really are stepping up and they really feel very strongly about helping people continue with their preventive activities. This is not an issue where providers are shying away from this at all. I think if they're well protected and they understand how to stay themselves safe, they really want to render care. And it's always been a privilege, not just from our own employees, but from these hundreds of providers that we work with around the country. They really care about providing these preventive services and they think it's high impact and they want to keep on doing it as long as it makes sense and it's safe to them and their families. So that's our experience. Dr. Walker, how's your experience in that?
No, I would agree wholeheartedly that docs are ready and raring to go to see their patients again, right? And even here in the Northeast where when we were at our height, they were mostly seeing patients through telemedicine, and for many of them that was a new skill set that they developed, right? But really, they now have that as an added tool, but that interaction in person, they are making room for that and encouraging their patients to come back to be seen and to have those preventive screening exams. And so, you'll find that at many doctors' offices, they're also doing temp checks before you walk through the main door into the waiting room. They're also having you do a questionnaire screening about travel and COVID contacts that you may or may not have had. And so, following those CDC guidelines, frankly, because yes, overall there's no strategy, but there are some guidelines out there that people can do to keep the office workers safe and the patient. And for the most part, people are doing that and making sure. And now that PPE is a bit more available, they're making sure that all of those who are in the offices are donning the appropriate PPE for the patients that they're seeing and procedures that they're doing. And so they're there ready and waiting, and we really need to be sure our employees get access to them while they can in the event that another shutdown happens, and then we're back to kind of square one. So.
Thank you. And Craig, you have the last word here. We're running up. What would you say from a payer point of view and getting people back and starting to consume healthcare services again? We're safe.
Yeah, I would just add that I think that a lot of the providers are doing a good job of reaching out to their patients. We're seeing that more and more, especially in the last 30 days, as they become more comfortable and are back online, reconnecting with their patients, promoting this, talking about safety and the measures that they've taken to calm the fears of some of those high-risk patients and getting them in to treat. So I think the provider community is stepping up, and I think we're starting to see some of the results of that bounce back. We need more. We need to keep on that path. I think we're starting to see some of the results of that.
Well, I think we're at the end of the hour. I just want to thank both of you, Dr. Walker and Craig. I have to say these webcasts get better and better every time we do them, and this is no exception. I think that what we discussed today and your insights were particularly engaging and interesting, and I think relevant for all of our clients who've signed in. And this will be recorded. Those of you who know, you can always reach us through our COVID line on the web, or we have an 800 dial-in number to answer any questions for our employers, and obviously for all of your populations, your employees and beneficiaries. But I just want to thank you, and we're going to be taking up the subject again in a few weeks, right after Labor Day, this issue of vulnerability and this issue of could there be could there be an epidemic after this epidemic is done of really of lapsed care, and what does that really mean for us? So again, thank you. We really appreciate your time, both Craig and Dr. Walker. Really very much appreciated, and have a good weekend to everybody. Thank you.